Good afternoon, everybody, and welcome to our second week of rural onboarding. I'm very excited to have you all here and very excited for our speaker this week. So last week, we started off with infectious diseases. Always good to get going with HIV and TB. But this week, we're going to move on to maternal health. I am going to ask all of you to please mute yourselves, and as you come on, I'll try and keep track of the list as well. So I would like to welcome Dr. Mandondo here with us this evening. She is one of our great local mentors where I live. I'm here live from Intra in the Eastern Cape. And the area around East London is called the Amathole district. And since Dr. Mandondo has been involved there as a DCST, we have seen a huge impact on maternal health in our district. And it's really made such a big difference. And she's very much hands-on. So she comes, visits all the different hospitals, and you'll see her often in your theaters, and very much helping and engaging our young rural doctors. So tonight, our topic is going to be specifically focusing on CTG interpretation. And I just want to introduce Dr. Mandondo, and then I'm going to hand over to her. So Doc is currently a DCST, that's the District Clinic Specialist Teams O&G in the Amathole district of the Eastern Cape. And she represents the Eastern Cape in the Ministerial Committee NCCEMD. She was the winner of the Sama Border Region Local Hero Award for Maternal Health in 2017 for her extraordinary work in maternal health in a rural district in the Eastern Cape. She's passionate about community obstetrics and developing doctors, as well as cervical cancer prevention. She's also a married mom of 3 kids, although I think all the doctors in Amathole is part of her kids. So I'm very happy to hand over to her, where we're going to go into a real nice practical skills building workshop. Welcome, Dr. Mandondo.
Thank you very much, Madeleine. Appreciate that. I'm going to then share my screen. Is it visible?
Yeah, that's perfect. Thank you.
Okay. Is it on slideshow now?
Yes, we can see it on slideshow now.
All right. Good evening, ladies and gentlemen. Welcome to our talk, and we are privileged to have you part of this talk. So I think that we've selected CTGs because CTGs are important. And what are the 2 reasons they are very important? Is because babies die when CTGs are misinterpreted or they are not interpreted. And if you're looking at some of our deaths, there is something like CTG has been done, but intrapartum or antenatal, but the CTG has been interpreted incorrectly. And that could be a reason, but also because the Department of Health is bankrupt. And it is bankrupt because patients are litigating, and there is a huge cost to litigation. For example, in our district, in our province in Eastern Cape, I mean, we've got 29 billion rands worth of litigation, which is actually close or is now going to exceed the health budget of the province. So that is why it's very important that we all pay attention to this particular talk. So I'm going to use just in terms of acknowledgement, I'm going to use the ESMO slides, and I've borrowed some of the slides from Prof. Hofmeyer, and then there is Prof. Stier, who's from the Royal College of O&G, who has produced some slides because he does some CTG workshops. So I'll use some of his slides as well, the practice slides for the practice side. So really the aim of the talk is really to evaluate a CTG, to understand the components of a CTG, to recognize normal from abnormal CTGs, and really to learn how to respond to abnormal CTGs. I see many people are able to say, no, it's suspicious, but then what is happening clinically is very important, and what are people supposed to do? How will you respond? Before you say, oh, I will cut, will prepare for Caesar, there are actions that are expected to be taken by the person who's in the CTG. So we're going to stress that in this presentation. So basically, how to assess the well-being of a mom? So it's very important that when you're admitting any patient, firstly, you want to know if the baby is alive, but you know what? Fetal heart rate assessment is actually very important to assess the well-being of a baby intrapartum, but we do CTGs antenatally as well. So before we start focusing on CTGs, there are questions we need to ask. Screen the mothers if they have good fetal movements. Be aware that these fetal movements will start after 26 weeks. If the movements are reduced, the mother must know what to do, but you must also ask the mother to demonstrate by ticking on the maternity case record to see how many kicks the person can see in 30 minutes or an hour, of which you expect to have about 6 kicks. And then also, if there is a concern about the kicks, then you need to be checking how was the growth, was the poor growth or what, and then CTGs. Then CTG could be antenatal or intrapartum. So we'll discuss that. And then we'll talk about the acoustic stimulation test. So when you're doing a CTG, the very first thing, it's very important that the mother is semi-sitting with a lateral tilt, because you don't want, once you're doing the CTG, people to have the superior vena cava compression, which is going to cause changes in your CTG. So the way she's positioned before you start is important. 2, you auscultate for the fetal heart, because the CTG machine cannot read whether the heart that it is hearing is the baby's or it's the mother's. So you need to first auscultate and differentiate. So you locate the pulse of the mother, and then if you can determine that it's 100, then you check the babies, and those two must be different. So it's very important that you do that checking before you start tracing. Then you locate the mother's heart, and then you secure the transducer. And then a CTG is not a CTG. This is a cardio-tachogram. So you cannot run CTGs without running a tacho belt. So you need to put the tacho belt on the uterus to be able to compare what is the response of the fetal heart rate to the uterine contractions. The third thing is you need to actually verify what is the rate that the CTG is set at. So I'll teach you how to recognize the rate. Some CTGs will run on the trace. It will be written 1 centimeter per minute, but this is our universal standard that we're using for CTG interpretation. So your CTGs must be running at 1 centimeter per minute. And then really the name, the date, the time is very important. And then you actually have to see if you're doing antenatal CTGs, normally it's 10 to 20 minutes, right? But we want to see that accelerations are same. So if there's no acceleration after 10 to 20 minutes, you can do an acoustic stimulation, and then we can actually do it so that you can then get an acceleration so that you can start your CTG. So this is very important in terms of the technique. My slides are not moving.
Just tap on the slide itself. Sometimes it gets a bit, just move you and then tap on the slide. There we go.
Okay. All right. So when we are using the National Institute, the NICE guidelines, right? So the NICE guidelines are developed in the UK. And this guideline is what is called the intrapartum care guidelines. So when we do CTG interpretation, you can use FIGO guidelines, but in our context and for the purpose of this lecture, we're going to be training you on the use of the NICE guideline. Okay, so in terms of the features, the contractions are the most important, though they do not form part of the classification of the CTG in terms of the NICE guidelines. The contractions are often the insult that is going to result in the abnormalities that you will see on the CTG. So it's very important that you note what is happening to the contractions, and we'll talk about that. Then the features that form part of the classification is the heart rate. There will be variability, there will be accelerations and decelerations. So going forward, the accelerations, you pay attention to accelerations mostly when you are doing an antenatal CTG. Intrapartum, we do not focus on accelerations. They're not even used in the assessments, because when a patient is intrapartum, it's very rare to see accelerations. But if you are doing an antenatal CTG, it is absolutely crucial that you see accelerations of the trace to know that the baby is well. So in terms of the critical nomenclature, a lot of people are not clear about the variability, and that becomes the main thing. So accelerations are normally 15 above the baseline. Decelerations are also below the baseline. You can see that the deceleration is a drop in the heart rate. And acceleration is an increase in the heart rate, which is normally 15 and above. But now, if you just look at this trace, you normally have a baseline for the heart rate, and then the heart rate varies from one beat to the other. Okay, so the important thing to understand about the variability is that in basic physiology, every fetus has got a sleep and a wake. We call it a rapid eye movement and a quiet sleep. So when we're talking about quiet sleep, when you are in quiet sleep, which normally lasts for about 20 minutes, the heart rate remains the same. And therefore, you will have no variability. So if the baseline heart rate is at 120, most of the beats within that 20 minutes will be at 120. And therefore, there will be a loss of variability that will happen during that time. And then, if you then have rapid eye movement sleep, so it's more like the baby is now awake, but now with rapid eye movement sleep, there is a difference between each heartbeat. So one heartbeat will be 120, the other one 130, the other one 125, and back to 120. So the CTG will connect the dots, giving us this short-term variability that we are actually talking to. So it's very important that we know that this is the normal behavior. So for every CTG that you do over 50 minutes, you must expect that you'll have a flat portion where the baby was in quiet sleep, and you will have one with good variability. And that's normal, and that is physiological. So it must be expected in every trace that you are doing. Okay, everyone knows this. I'll just rush through it. What is the normal heart rate? So on the heart rate, our normal heart rate is 120 to 160. And then we've got this borderline bradycardia and the borderline tachy. So the borderline bradycardia is between 100 and 109. And our borderline, our moderate tachycardia is 161 to 180 beats. You know, this could be because of things that are easily reversible. Things like just dehydration, just hypotension when the mother is lying down, then you find these changes, which is if you do the appropriate action, this heart rate will return to normal. But now you can have this abnormal bradycardia where now the heart rate is less than 100. When you see a heart rate less than 100, you must know that this is very pathological, and it means that the baby could potentially die. But also, the first thing you need to do once you see a heart rate less than 100 is to verify, is the baby still alive? What is the heart rate of the mother? And that will give you ideas. So this is going to be our very, very first trace. And I want us to look at this trace and just really look at a pattern, and so that we can see what you need to recognize. So the first thing we said, it will be the name, the time, the date, and then if you can see here, then the paper speed. Okay, so how do you tell the paper speed? Is anyone willing to tell us what's the paper speed on this CTG? Is it running at 1 centimeter per minute? Is it running at 2 centimeters per minute? And how can you tell? Anyone can unmute themselves?
They can unmute, or you can put your answers in the chat. That might be easier. I'll keep an eye on the chat as well.
Oh, okay. So they put the answer. So if you have, when you have a CTG, you've got the two big lines, the one that says 200 and 200. In between those, there's 10 lines. So each of that line is equivalent to 1 centimeter. So in order for this CTG to be running at 1 centimeter per minute, you should see the CTG will print the times. So you can see that in this tracing, it says 09/05/2001, and it says 1500. And then it skips the next bar and it goes to the third bar, and it says 1510. So this is a way of verifying the time. So you can see that if this CTG was running at 1 centimeter per minute, it should have said 1500, 1510, and right at the end, it should say 1520. So that is your first check before you proceed. Then we move to the second thing. So the second item that I want you to focus on, for example, if you had not seen that the CTG was running at 2 centimeters per minute, there is 5 contractions here in 10 minutes. A person would have easily said there is 3 contractions in 10 minutes. So it is very important to first establish what is the paper speed that the CTG is running at before you give an answer. So in this CTG, the paper speed is 2 centimeters, and the number of contractions there is 3. So let's come to the behavior of contractions. what you can see on this trace is that you will see that when you're looking at contractions, you want to see the shape and you want a rest, because when there is a contraction, the baby is quite asphyxiated. So once the contraction ends, the baby needs about 2 minutes to be able to rest, and then so that before the next contraction starts. So all the time you want to see that shape, that the contraction starts, there's a rest, the next contraction starts, there's a rest. And ideally the contractions should be less than 60 minutes in order for the baby to cope. Then the third thing we talked about just now was the variability. So we can see here that the variability is mainly at 120, but you can actually see that the variability is actually good. So which is now, when we express variability, we talk about the difference from the baseline, between the baseline and the highest, and the accelerations, or the highest point of the heart rate. So you can see here that this baseline was sitting at 120, and there were some beats that were at 140, and there were some beats that were at 120, at 110. So basically, the difference is 5 beats. So you have a variability, which is normal. It must be between 5 and 25 beats per minute. So that's a normal variability, which is the difference between the highest and the bottom one. So the variability, this is the minor fluctuations. They're measured as the difference in the beats per minute between the highest peak and the lowest trough, right, in a 1 minute section of the trace. So therefore, we talk about, now we just focus on the short-term variability, which is what we refer to. So the normal baseline variability will be between 5 beats per minute, but it's normally less than 25 beats per minute between the contractions. So when you have now, remember we said that when the baby is in quiet sleep, that can happen for about 20 minutes, so which will be normal and physiological. But when you have a baseline of less than 5 beats per minute for 40 minutes or more, but less than 90 minutes, then we say that is a non-reassuring sign. And then when you then have this lasting for more than 90 minutes, then according to the NICE guidelines, it's pathological. So no baby can remain in quiet sleep for more than 90 minutes. So that becomes extremely pathological, and we need action. We actually need delivery. But we're going to discuss what then do you do when you find that you've got reduced variability, and that reduced variability is for 40 to 90 minutes. So when you have reduced variability, drugs are very important in terms of causing the reduced variability. So which drugs? So firstly, it will be pethidine, right? Pethidine, morphine, all your opioids, they can reduce the variability. The second drug is when the person has received magnesium sulfate. So magnesium sulfate tends to drop your variability. And that can happen for almost more than 2 hours, or for as long as the magnesium sulfate. But if there's no other features, then you can say that in a patient on MagSulf, you can say that the variability is being reduced by the MagSulf, but you must not have other features that are non-reassuring other than this reduced variability if you think it's due to the drugs. Okay, now contractions. We've talked about contractions, duration, frequency, form, relationship to heart rate. And a lot of people like to think that when you see high peak in the talk, or you think there's strength, but the CTG cannot measure the strength of any contractions. So what we are concerned about with the contractions, it's the number of contractions, right, occurring over 10 minutes. So the maximum number of contractions should be 5, and they should not last more than 60 seconds. Because remember, as the medical students, we all used to palpate the contractions and we say, no, up to 20 to 40 seconds, and then we'll say 40 to 60. But we didn't have contractions that were more than 60 seconds. So it's the same thing. So every contraction should last within that 60 seconds. Now, what is the problem with increased contraction? So they will result in fetal hypoxia, as there is reduced blood flow in the placenta during contractions. So there are situations where we get tachysystole, where you get more than 6 contractions in 10 minutes. So we call this also hyperstimulation. So how will you, if you're looking at the tracing that I'm showing, this is showing, you can see between the 2 bands, you can see almost 7 contractions. So this is what we call tachysystole. Now, when you have tachysystole, then it will result in what? In the reduction in the heart rate. So how are you going to deal with tachysystole? Firstly, you must identify the causes of the tachysystole. So one important cause is patients that have been, that are being induced, that are receiving misoprostol. So when you see tachysystole, you should ask yourself, has this patient been receiving misoprostol? Number 2, patients receiving oxytocin. I normally to say to people, oxytocin has no color. And I know in many labor wards, people use oxytocin without putting a label on the drip to say they've used oxytocin. And this is illegal, colleagues. That practice has to stop in our labor wards. If you use oxytocin and you think it's indicated, then you must have a normal CTG and start the oxytocin, record and document that we're starting oxytocin and this is the drip, this is the rate, so that when tachysystole happens, sorry, I got interrupted there. When you start seeing tachysystole, then you will know that it was due to the oxytocin. Thirdly, I don't know in other provinces. In our province, we have got the use of, they call it umcamemphen, or this traditional herbal medication that patients are taking. So you could see a patient with tachysystole due to that herbal medication. So we must really take note of this and really ask the questions when we see it and really stop oxytocin. If you were inducing a patient, you must note the time, because within 6 hours of misoprostol, you can't use oxytocin. So this could be the result. This could result in the type of picture that we are seeing. Okay, I'm gonna show this trace. And here again, I'm focusing on the contractions. So you can see here that we said the shape and of the contractions is concerning. So you actually have a contraction, and then what then happens is that before the contraction has ended, on the third one, 1 is normal, 2 is normal, but on the third one, we actually see the third contraction starts, it doesn't go back to the baseline before, and there is no break in between, and the 4th contraction is starting. So this is what we refer to as coupling of contractions, which we really need to focus on, the coupling of contractions. This is what it looks like, and it therefore causes a prolonged period of asphyxia, and then will cause fetal heart rate abnormalities. And then we also talked about the issue of the strength of the contractions. So if you see this CTG tracing, we're still talking about contractions, we're not focusing up there. If you look at these contractions, the contractions are there, they look shallow. You can count the numbers. So when we look at contractions, we do not talk about strength of contractions. This patient, you're not gonna find her screaming and in pain, and you say, oh, what's wrong with this mommy? Because she hardly has any contractions on her CTG, she's screaming. No, this patient is obese. What happens is that the torco belt, if there is a fat barrier, it impedes the ability of the torco belt to sense the contraction. And therefore the tracings will appear like it will be a bit looking like it's shallow when you look at the torco, but the contractions are strong. So don't focus on that. Just focus on the number, the shape, the form, and you want to see the duration. Okay, then we have this, what we call a flat CTG, right? So this is a CTG with no variability, right? Or poor variability. And what did we say? We talk about 3 things. It's pethidine, it's Maxal. And the third one that I did not talk about is if the patients, there are patients who drink, they come into our labor wards, they are ethanol intoxicated, and it is quite expected that because ethanol crosses the placental barrier, it actually causes a flattening of the CTG tracing. And therefore you will have a reduced variability for longer than that 40 seconds that you actually tend to expect. So this can be noted in a patient with who's also exposed to ethanol. So you are ethanol intoxicated patient. So you need to actually record this and know that it could be the reason. But now what do you do? How do you deal with these flat CTGs? You will see a lot of them, but the instruction is very clear. Once a CTG, you see a CTG that he is flat, you do not stop the CTG in the first place. You need to continue with your trace for up to 90 minutes, right? And then at 50 minutes, it's actually the deciding time. right? If it remains flat, it's time to really notify your senior, call someone so that we do not delay our CTG. So, and then the second thing, you continue the trace. After continuing as you continue the trace, you need to do what is called an acoustic stimulation. So basically, when you do an acoustic stimulation, you really need to use an instrument, right? And you want to do a sound that's actually going to cause a loud sound like, ah! You know, that's what you want to create, which is going to transduce through the lipo, go to the fetus and cause an acceleration. So what you need to do, if you are using a coke can, you need to support the upper rim with your thumb and the third finger and depress the ring opening with your second finger and allow it to step back, giving you a twanging noise. Continue to count the fetal heart rate for up to 30 seconds. Then if the heart rate increases by at least 8 beats over 30 seconds, or if the mother really feels distinct movement in response to the stimulation, this is actually promising that the baby then, the tracing will start to improve and will start showing good variability. So this is the demonstration. This is the coke can. This is Prof. Mayer's hand and trying to demonstrate this. So in our labor wards, yes, other people use metal, but we can keep the coke cans, and then we're going to use the coke cans to flick and to do the acoustic stimulation and see how the fetus is going to respond to that acoustic stimulation. And that will be able to, it's your test to say, if it improves, then everything is good. If it remains flat, then you can say that this is pathological. Now, I will show you, I have seen a few deaths recently. These colleagues, the reduced variability is not something like this. If you're looking at this tracing, there is such reduced variability, but it's associated with what? With this shallow deceleration. So you're not going to overlook this and say, no, I'm going to continue with this trace. This is not just a flat CTG, right? Therefore, if the mother has reduced the variability, the baseline is usually normal, but there's reduced variability, shallow prolonged decelerations. This is a terminal CTG. So let's not confuse what we call just a flat CTG and a terminal CTG. This is what it looks now. Also, you can have a situation where if in the CTG that I'm showing now, you can see that it was also very flat CTG, but it's showing these small decels, and you're actually seeing the wandering baseline. The baseline was low, then it starts to be borderline, then it goes even lower. So this is what we call a pre-terminal trace. Within 15 to 30 minutes, this baby would have demised. So it's actually very important with these intrapartum CTGs to note the difference between just the reduced variability to the one that is almost pre-terminal, which is what you're seeing here. Okay, and then the other thing is sometimes the baby dies. So you may see this heart rate, and then maybe somebody didn't see this CTG, and then in 10 minutes time, you see this CTG, right? And you are confused, right? So what has now happened is that as this baby has demised, you start picking up the maternal heart rate. So how will you differentiate between a bradycardia due to a maternal heart rate or a bradycardia from a fetal heart rate? You are going to see accelerations when there is a contraction. So if you can see here, you can see there's lots of acceleration during a contraction. So this is actually due, and when there is pain, this is actually a maternal heart rate. So you will find people will take a patient with a fetal brady to theater, and then they get a macerated stillborn or a fresh stillborn because they missed the issue of this heart rate. I'm going to move colleagues to talk about decelerations. And decelerations, a lot of us talk about early and late decelerations. And decelerations is actually the response, right, of the vagal nerve, right? And it is because of contractions. So when you have contractions, you compress the cord. The cord can be compressed by the baby herself. They can hold the cord, they can lie on the cord, or it could be contractions. Because the contractions are happening, they compress the cord. So this will cause an increase in the arterial pressure. Now, when there's an increase in the arterial pressure, then this is going to cause a stimulation of the cardio inhibitory center, cause vagal stimulation, and it will cause a slowing of the heart rate. So this is actually physiological. Remember, with CTGs, we are not measuring the heart. We are measuring the functionality of the brain. That is why if the CTGs are misinterpreted, you get cerebral palsy. So we're using the heart is a proxy for the cerebral function, you know, which will then regulate the heart rate based on the signals it's getting. So when there is a, so if there is a stress on the baby, yes, you'll get the variable decelerations, but you first start off having reduced movement, reduced breathing movements. Then with cord compression, you get a vagal bradycardia, which then protects the fetus from the hypertension. And then from that, you get hypoxia, right? And therefore, this is due to now vasoconstriction in the non-essential organs, which then causes a vagal bradycardia or late decels. And then late decelerations then can also be detected by auscultation. So in Dublin, for example, they don't use CTGs. They only have midwives that listen to the contraction, to the heart rate of the baby after a contraction. And it will sound like this: doom, 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 doom. So that is the late decelerations. After a contraction has ended and ceased, you still continue to get a slowing of the heart rate, which then may increase after a while back to the normal, to where it started. So now I want us to focus on this because I think this is the most poorly understood part of the CTG, the decelerations. So one, we're going to say deceleration. All of us know early or late, right? So which is just the timing. If it happens, the contraction, the heart rate goes down immediately during the contraction, we call it early. And then it has become normal at the end of a contraction. Late is it continues to decelerate after that. Okay, but let's look at the three things that I'm talking about. The depth of the deceleration, right? The duration of the deceleration. Is there a recovery after a deceleration has happened? So early decelerations, they are repetitive slowing of the heart rate, right? Okay, with onset early in the contraction and return to baseline at the end of the contraction. So if we are looking at this picture, the second thing I want to emphasize on the contraction is the number of decelerations to the number of contractions. So they must be repetitive and they must occur with 50% of the contraction. Can I just show this again? Decelerations are what? They must be uniform, repetitive, associated with more than 50% of contraction. So that's the second point that you must be aware of. So let's look at these decelerations. So if we look at this trace, we can see the number of contractions: 1, 2, 3, 4, 5, 6, 7, 8. And you can see you have 1, 2, 3, 4. So you've got enough decelerations to make this a repetitive decels, right? Then you look at the depth, right? So in this case, most of it was running at 140. And you can see that every time the heart rate goes down to 60. So that is worrying because if it runs, if the heart rate slows, you know, by more than 45, it's a worrying sign. Then in terms of timing, they were happening with the contractions, but after the decel, there's even an acceleration after this. So there is a good recovery. So if we're looking at this trace, we can say that we won't say these are early decelerations. We're now going to change them and we're going to call them variable decelerations. So what are variable decelerations? One, the deceleration is variable if the depth of the contraction of the reduction in heart rate is more than 45, right? And then that we're going to refer to as not an early deceleration. Now we're going to call it a variable deceleration. But let's look at another context. So if we saw at this CTG, we can see that now here we've got a reduced variability and we've got shallow early deceleration. Why are we saying they're early? Because they are rarely at the same time as the contraction. And it's also, the decel is over by the time the contraction is finished, but it's associated with reduced variability. So whenever you see early decels associated with reduced variability, you don't call it early decels, you call it variable decelerations. Okay, now we can have something else which we'll call a single prolonged decel. Okay, so we can type on the chat, what do you think will be the causes of these single prolonged decelerations? So we can see here, because this CTG is running at 2 centimeters, we're seeing almost 4.5 minutes of a deceleration after a normal good variability. So when you see a single prolonged decel, you must ask yourself, what is the insult? What has caused this? So this is actually very common when the mother is lying supine, and then they have a, and then they get this supine hypotension. And if you check this mother's blood pressures, so if you see this, your response as a clinician, remember we're learning about response here, should be immediately to turn the mother to the left lateral position. You can actually measure her blood pressures. And if you find her blood pressures are 80/40, then you will know that this was postural, and then you can actually run a drip to actually infuse some fluid to really improve this hypotensive episode. But it could also be due to vomiting. And then the last one that is very important is when you have a cord that is now prolapsed. So let's say she ruptured membranes and she prolapsed the cord. So in addition to doing the vitals, giving fluid, you need to pivot this patient to make sure that there is no cord that's presenting, or there is a cord that is prolapsed that has caused this single prolonged deceleration. Okay, we're now going to move on. So remember, we talked about early decelerations, which are normal. They tend to be physiological as long as the heart rate doesn't drop too low. Then we talked about variable decelerations, where we said that it will be an early deceleration associated with a reduced heart rate, or it will be an early deceleration where the heart rate drops by more than 45. It drops quite significantly when there is a contraction. Then now we talked about the single prolonged decel, okay, which is dangerous. If it lasts more than 5 minutes, that episode could possibly kill the baby. Therefore, it's actually very important that if these last more than 3 minutes, that baby, we need to consider whether we are delivering that baby. That is pathological feature. Now let's look at late decelerations, right? Can we see again the definition? Let's focus on definitions. It's uniform, repetitive decels occurring in more than 50% of contractions, right? Now, what does it do? It causes a periodic slowing of the heart rate from the mid onset of a contraction, but then it continues to drop to well ending after the contraction. So if we looked at this trace, you can see that the contractions 1, 2, 3, 4, 5, 6, 7, 8, and you can see there's almost lots of late decelerations, and they happen after the contraction has ended, and they continue to slow down with reduced variability. This is pathological, colleagues. We need to prioritize this baby for delivery. So some of the units are quite busy, and you may find that you get these decelerations, these late decelerations, and sometimes you need to prioritize between 1 or 2 scissors. So you see on the left where we have the picture with the loss of variability, with the title loss of variability. That is a concerning sign, because now you've got decels with loss of variability. But now, then you've got biphasic, and then you've got this one where there is a slow recovery. It's a sinister sign, because it means that the period of the slowing of the heart rate takes a long time. And then in the third one, the last one on the right, there's a continuation of the baseline at a lower level. So now, if you had patients with the different CTGs, let's say you have three patients, all of them are waiting for Caesar, and now you need to pick which one are you going to operate on first. So I would say that the one with loss of variability is bad. The one with a slow recovery, I would always prioritize the one where you have a decel, but the heart rate is unable to return to the baseline. It comes back at a lower level after these decels. This is a dangerous one, and we need to intervene. We'll start with that Caesar, where the continuation of the baseline is at a lower level. Then we are dealing with our last in terms of the decelerations. We have decelerations occurring without any contraction. So these are spontaneous decelerations at rest. So how are we going to improve our antenatal care? We're going to improve it by doing antenatal CTGs from 26 to 28 weeks in high-risk patients. The ones with preeclampsia, the diabetics are very important. Why are we doing that? It's because we want to pick up when you get to end-stage placental insufficiency. The tendency is that when you do an antenatal CTG, you will see the decelerations spontaneously in a person who's not in labor. So if you see these spontaneous decelerations, they are pathological. And what do they mean? They can mean that it's the first sign, this is the first clinical sign that the patient is having an abruption. And we know that abruption is a very dangerous and it can kill babies. But the second thing is it's because end-stage placental dysfunction has happened. So this mother baby needs delivery. So this is what these traces look like. You can see on the top of that, it's completely flat, and you can see these decelerations happening spontaneously. So we need to deal with that. And then the last one we're going to talk about is what we call a sinusoidal CTG. All right, so sinusoidal CTG, we can see it in those patients who are anemic with resus sensitization, but you can see it in any other patient that is like actually at the end, like that's dying. So what is it? You can see this trace. You cannot establish where's the baseline. You can establish where's the heart rate. You just see a continuous wave-like form where it's difficult to establish where you are. So this is what you see no fetal movement. Sometimes the baseline is usually around normal rates, but you'll have reduced variability and you've got these sign-like fluctuations at 2 to 5 cycles per minute. And this is what we call a sinusoidal CTG. And this is an imminent sign of death. So in summary, what are we saying? In the CTG, you've got normal features, right? Or reassuring features. So you know when you have a heart rate, what are the reassuring features? Heart rate is normal, variability is more than 5, there are no decels, and the CTG is present. So you will say that everything is reassuring here. So this will be your normal CTG. But now you can get what is abnormal, you know? Now abnormal is when you have a fetal brady less than 100. When your heart rate starts exceeding 180, it's difficult to maintain perfusion to the fetus. And when you see the last trace that we've seen of a sinusoidal pattern that occurs in more than 10 minutes, that is abnormal. Then when it comes to variability, when you've got a less than 5 for more than 90 minutes, it's abnormal. And then we have done away with the typical or atypical variability, but we normally, variable decelerations. So we just talk about deceleration. So what we talk about now is that late decelerations and then single prolonged decelerations of more than 3 minutes are regarded as abnormal. And then when you have an abnormal sign on the CTG colleagues, you've got 30 minutes to deliver the baby. 30 minutes is not a Caesar, but if the Caesar, the patient is not in labor, yes, it will be a Caesar. Whether it's a vacuum or a Caesar, it's acceptable. But if you have abnormal signs on a CTG, you cannot keep the mother for 2 hours with abnormal signs. When you see these signs within 30 minutes, there must be an action. Then you've got the non-reassuring signs. So this is the borderline bradytachy, and then there's that reduced variability for 40 minutes. And then we've got what we call variable decelerations, right? Or single prolonged deceleration for which lasts at least 3 minutes. So this is non-reassuring. So what do you do if you see a non-reassuring sign on a CTG? You repeat the CTG in 2 hours, right? Not 4 hours. In 2 hours, you need to identify what was causing this non-reassuring sign. We're going to discuss that. So it could have been just dehydration. So just by putting up a drip and infusing fluid, then it may have been just maternal dehydration that was causing the tachycardia. Or maybe it could have been a patient who was doing a VBAC and the sky is starting to dehisce. Therefore, you're going to get a fetal tachy. So you need to identify what was causing this non-reassuring. It's not good enough to just say, repeat it in 2 hours, but you need to do some other actions, position fluids, antibiotics, to establish the cause, and then you can then review in 2 hours. And if it still remains, this non-reassuring feature remains, then it means that then you have to deliver the mother. Now, I want to make a disclaimer. Some provinces are using the new maternity case record. In the maternity case record, there is a sticker there. And that sticker on the maternity case record is based on the FIGO guideline. And what has happened in the FIGO guideline, they have changed the times for this abnormal CTG. So they have said the CTG, if the variability is less than 5 minutes, then it warrants a delivery, a decision for a delivery, and then you can start preparing the mother. So by the time you're delivering the mother, it will probably be that 90 minutes time. The decision time, I will show the sticker for those of you. So in terms of describing a CTG, colleagues, we have talked about the date, the paper speed, contractions, heart rate. We've talked variability, accelerations, but you need to categorize. When I trained as a medical officer, we had reactive and non-reactive CTGs. That nomenclature is no longer appropriate in our practice. The CTGs must clearly be stated as normal, suspicious, or pathological. So that is the language we are using. And number 2, categorizing without managing the patient is not adequate. So the reason we are being sued and we are paying so much litigation is because we do not manage our abnormal CTGs, and it still yields poor outcomes despite the clinician having recognized that the CTG was abnormal. So I'm going to stress the issues of management going forward because we've discussed how to judge. So how are you going to discuss the management? So some of you know this mnemonic that says Dr. Mandondo. So what does it say? You have to define the risk. The DRN define the risk. C is look at the contractions. Then you look at the baseline variability, decels, and then have an overall impression about the CTG. Why must we define the risk, colleagues? For example, if a patient is doing a VPAC, so when you present a CTG to your senior, especially for the junior ones who are starting now, you must first define the risk. So what will you say? You're gonna say, Dr. Mandondo, I have this patient who has a fetal tachycardia with a background that she is doing a VPAC. She had a previous Caesar in 2019. So now when you say that to me, it's completely different when you have a prima gravida who is now very restless and agitated and shouting and screaming, who has a fetal tachy, because that patient may just be dehydrated, having labor for a long time. But the patient where you said it's on the background, the risk is that she is doing a VPAC. It means that fetal tachycardia in a patient doing a VPAC could mean a rupture or a scar that is dehiscing. So there is no room whatsoever, colleagues, to repeat the CTG. When you start seeing fetal tachycardia in a patient who's doing a VPAC, it means immediate delivery. So that is why it's important to do the defining the risk. So we said our categories will be normal, suspicious, pathological. And so if all the features are normal, it will be normal. If there is one non-reassuring category, then we're going to say the CTG is suspicious. You're only allowed to have one non-reassuring category. But if you've got reduced variability for more than 40 minutes and a heart rate of 165, that is 2 non-reassuring signs. So when you've got 2 non-reassuring signs, then it makes it pathological. Or if you have any one abnormal category, then it makes it a pathological CTG. You must note this. Okay, so I'm going again, defining the risk, right? Diabetics are high-risk patients, preeclampsia, GPH, right? And then there is something to decide on your action. You could have been monitoring a patient for a long time, but there are events that then happen in labor. And one of those is an abruption or the onset of LPH. So now you have a precipitating event. So you must also ask yourself, when you're deciding on the action, you ask yourself, how far is this person in labor? So if you see variable decelerations in someone who's 3 centimeters, that's very worrying, even though it's suspicious. In 2 hours, she'll still be 3 centimeters and she will need your Caesar. But in someone who's 8 centimeters, they could deliver even within the 2 hours and rupture the membranes, and you try to make things go quicker. Therefore, the progress is already advanced, and the likelihood that she's going to deliver within the 2 hours before you're reviewing a suspicious CTG is actually very important. So I'm going to just show some traces, and I want to acknowledge that some of these traces come from Prof. CS training. So the first one I'm going to show is, you can put on the chat, is this normal or is this an abnormal trace? You can chat, put it on the chat. So the most important thing is that in this CTG, right, other people say the baseline is at 160 and there's accelerations. Other people say the baseline is at 180 and there's deceleration. So I think the important thing is that there is evidence of fetal movement here. So I think that the problem is that there's multiple accelerations with a baseline of 155. So you must see the CTGs in context. This is a normal CTG. This CTG is actually showing you something which is quite common, and it confuses a lot of the interns. And what happens there? You can see that at the beginning of the trace, you see these shallow, these decelerations, right? You can think you've got late decels, right, in the fetal tachy. But then within hardly 10 minutes, the CTG has normalized, right? So I think the most important thing, this tracing is normal, although the first section could be interpreted as a baseline tachycardia with late decelerations. The second part is very normal. So, and this could happen just because of the way the mother was lying. Then if you're looking at this CTG, this tracing is abnormal. And what has happened here, you've got late decels, right? So this is just showing you that here's a contraction and there's a heart rate is slowing. So this is a fetal tachy with late decelerations, right? Okay, so now just taking you to, we are running short of time, just showing you the CTG and how to complete the sticker on the CTG. So if you're looking at the CTG, right, we can see a contraction and deceleration. So what we have now is this CTGs. This is the CTG interpretation sticker that I was showing you, which is based on the figure. And what is meant to happen is that CTGs can fade, they can get lost. So there's 12 pages allocated to you interpreting the CTGs. I've made a mistake here on this. So if you see the heart rate was 165. So this is not normal, all right? And then the variability was reduced for 25 minutes. And then you had repetitive late deceleration. So this is showing you in the first column, it's all the normal features. In the last column, it's all the abnormal features. And then in the middle, it's any abnormality that you can see on the CTG, but you need to write it with your hand. So for example, this one is giving you 160 to 110. And yet the heart rate of the CTG was 185. You write it with your hand, heart rate 165. If you see variability is reduced. And then it asks you the contractions, are they regular, irregular? And then it puts here clinical management. So you can write with your hand that you write the patient on the left lateral position, you give a fluid bolus, you can give a salbutamol, and you prepare for a seizure. So when you see late decelerations or abnormal features, there is a space here to say immediate action to correct the reversible causes. And then you can just put in your shorthand some of the things that you did. So there is a space for the time and the date of the CTG. So this is expected of your colleagues in terms of the CTG. So I've got a few more CTGs to show. So if you see this CTG, it started off well with normal contractions. And then you've got a period of tachysystole. And then what happens, you got this decel. This prolonged decel is not even more than a minute, right? It's less than a minute. But after this decel has happened, you get an acceleration, right, with good variability there. You've got a good recovery. So there's a fetal heart rate deceleration of 85, and this is secondary to that tachysystole that you saw. And then there is a reactive tachycardia. So this is just due to catecholamine release. And then this is what I want to demonstrate, the reduced variability again here. So you can see here these decels, right? When you look at them at a glance, you think that they are early. But what is worrying you is that the heart rate was at 180, it goes to 90. So it's reduced by actually more than 90 beats per minute, right? So you cannot say now these are early decelerations. You have to say they are what? They are variable decelerations. And then again here, these CTGs are the ones that cost us money when it goes to court, because you can see here that you've got deceleration, you've got deceleration, you've got decelerations. What type of decels are these? Really? Okay, so it's very important to note here that these are late decelerations. And also, but there is these decelerations which are shallow. And the second thing is, other than being they're associated with good variability. So you've got a normal heart rate, a normal variability, but you've got shallow decels. And a lot of people tend to miss these decels. So we need to pay attention to shallow decels in the presence of normal variability. People tend to misclassify. We've already talked about this one. Then here we've got oxytocin. And if you look at your contraction pattern here, there is coupling of the contractions, right? And the important thing here is that you can see the patient is on oxytocin. So the tracing shows a complicated baseline tachy with recurrent late decels. And you need to turn off oxytocin, put the patient on the left lateral position. You need to infuse fluid if she's hypotensive, give a tocolytic. We're using salbutamol, colleagues, to check your maternity care guideline, but you can use 250 micrograms of salbutamol and mix it with normal saline. And then also you need to check if the mother is parexial, so that you can give antibiotics to the mother if it's necessary. And then you prepare for the season. So it's very dangerous if you do not do these actions to improve, because this is what we call intrauterine resuscitation. And you want to optimize the fetus before you deliver, even if you're going to take it to Caesar, so that you can optimize her. And that is the repeat of the CTG that I showed. And then I want to show this one. So if you look at this CTG, it's actually very important to note that you have a loss of variability in the heart rate, which looks normal, but you've got this late deceleration. But what I want you to note is that this is an abruption evolving. So how will you see? If you're looking at the tocogram, you actually see a raised baseline tone with very frequent contractions, which is suggestive of abruption, really. If you have this type of case, you have to decide if it's really worthwhile even to going in to do the Caesar in the district hospital, because she could have a coagulopathy. So depending on your institution's the provincial policy, it may not be a good idea to do this Caesar, because you may find that it will kill both the baby will come out as an FSP, and the mother will have a coagulopathy. So here, what I'm trying to demonstrate is that if you've got a fetal tachycardia, so here we've got a CTG which was going well, then all of a sudden it's starting to show a fetal tachycardia. What do you do? So what are the 3 reasons a mother will have a fetal tachy? So the 3 reasons will be: 1, dehydration. Maternal dehydration is the first one. 2, there could be maternal infection. 3, we've already discussed it, is when you're having a uterine rupture, okay, in the context of obstructed labor. So we need to pay attention to this. And if you can see this CTG, right, as it continues, and you can see the mother's pulse is 120 and the temperature is 39, and this mother received paracetamol. So what I'm concerned about is that once you have this type of situation with the mother and she delivers, right? But now what about the baby? It's very important that this baby is also, if the mother is thought to have chorioamnionitis, remember the baby was swallowing that glycol. So the baby is at risk of getting nosocomial pneumonia. So it's very important that you take the baby, you admit the baby, you give the baby IV antibiotics, and then after day 2, you can repeat the CRP of the baby. If it's normal, then you can discharge the mother and the baby, but the baby also needs antibiotics. But if the CRPs are high, then the mother needs to be treated as a chorioamnionitis. The baby needs to be treated for the nosocomial pneumonia. Otherwise, these babies will demise at home because they are not symptomatic at birth. But then as they go home, day 5, day 6, they start being symptomatic, or they will not be feeding, and therefore they will come back. So I think that this brings us to the end of this lecture. I don't know if, I'm just going to show you something before I take questions. Here, this is what I had given as a handout. So I think in summary, we want to say, I'm going to start on the far right. Can you see this CTG? Can you see this algorithm? Hello?
Yes, we can see it.
Yes, we can.
Okay, thank you very much. So in a nutshell, colleagues, please, at the end of this lecture, I want you to clinically manage patients appropriately based on your CTG findings. So if you, I'm gonna start on the far right. If you have a flat CTG or reduced variability, what are the clinical questions you must ask? One, has this woman had an opioid? Has this woman have an epidural? Was she sedated or is she drug dependent? Did she use alcohol? Or did she receive any drugs that will suppress the CNS of the baby, which is normally Maxal? So what are you then going to do? You're going to do the acoustic stimulation with the cocaine, and you're going to extend the CTG for another 90 minutes, right? Okay, now what do you do if you see a mother with a fetal tachy, right? You check for maternal temperature, for pyrexia. What are the clinical questions you're going to do? You're going to examine and try and find where is the source of the maternal infection. You check maternal dehydration. So we do the urine dipsticks, check if there's ketones on the dipsticks, then see if there's signs of obstructed labor, and then you examine clinically to rule out a uterine rupture. So then if you don't see any of this pathology, then you can give antibiotics. So what will you do? So you will give some fluids, you can check the temperature and give antibiotics, and if there's oxytocin, you stop it, but then you can also do toccolysis, right? And you must remember that to trocholize with salbutamol, you cannot do it if the heart rate is more than 110, because salbutamol will cause a fetal tachy, a maternal tachy, which is so severe. And then you have to use 250 micrograms, right? You dilute it in saline, and then you can give it, and you can repeat it in 30 minutes because it works quickly. Within 5 minutes of giving salbutamol, the heart rate will slow down and will improve. Okay, so then what do you do if you see a CTG with uterine hyperstimulation? So one, you're going to say, is this woman receiving oxytocin, right? Or has this woman recently received a prostaglandin? So you check on the notes, you ask the nurses, if there's a drip up, it's not labeled, throw it away, and then take another drip and put it up. Don't give a fluid bolus on patients with hyperstimulation on the same drip they have, because someone may have added oxytocin and didn't tell you. So, and then you also check if you have received prostaglandin, misoprostol, or any traditional medication. So you can ask the woman, did you get any traditional medication depending on your local context? Now, sometimes you get this poor quality CTG and you're not sure, right? So what you want to do is you want to put reposition part. When you get this poor quality, sometimes it's the CTG machine itself, it's trying to check sometimes it's not sure where's the maternal, where's the fetal, and sometimes it cannot actually hear a proper fetal heart. So then you need to really go and check, is this a maternal trace that this thing is tracing? Because it can often be the position. Check the maternal pulse and look at the trace. Does it have accelerations with pain? If it has, then it's definitely maternal pulse, or you reposition the transducer and see if it will trace better. Now, the ones that are often controversial is these early decelerations called compression-reduced placenta perfusion. So it's when you've got early or you've got variable decels, what could be happening? Right, recheck the mother's position. Is she hypotensive? Has she just used a bedpan, vomiting, or being examined? But what you need to be sure of is you need to go and check if the membranes have ruptured. And in this context, it's often because of the postural hypotension. So you need to change the maternal position, check the blood pressure, give a fluid bolus, and then you must consider the vaginal examination to exclude cord prolapse. And my last one is to say, when you have this hyperstimulation, I think the most important thing is give the fluid bolus. Why are we giving? People just write, oh, fluid bolus. When, let's say somebody has hyperstimulation, you put the fluid, and then if you add 500 ml of fluid, you do two things. You dilute the circulating levels, right? Or the concentration of that oxytocin that she received, or that traditional medication that she received. The second thing is you force the mother to excrete, because now she's gonna pee it off. So when she's got that fluid bolus and she pees it off, then she excretes that product, and that hypostimulation will be improved, because remember, hypostimulation will cause meconium, and meconium will cause meconium aspiration. So don't just neglect hyperstimulation when the CTG is still normal. You still need to put up the drip, and really, if you think then after you've given the fluid bolus, toccolysis on its own is not going to do the trick. You want good excretion of the product that she took, and therefore at that point you need to look at it. So I think on that note, thank you very much for attending. I'm not sure if the poll is up. If Madeleine gave the poll, I would really like it. There's 3 questions or 4 questions that you put if the poll is up, but if the poll is not up, I'm going to hand over to Madeleine and I'll take any questions. Thank you very much.
Well, thank you very much, Dr. Mandondo. Now we've got a good 90 minutes we could fill. We normally sort of recommend talking about an hour, which you've done beautifully, just because people's brains start switching off. So we certainly have time for questions, and we're very happy for people to please post your questions on the chat or put your hand up and unmute yourself. But just to say thank you very much, Dr. Mandondo. For those of you that are feeling a little bit overwhelmed because there was an extraordinary amount of information in this presentation, that's a good thing. It means you're starting to get an idea of how much there is the art of looking at a CTG. And what we will do is we will be sharing this protocol, we'll be sharing some handouts, this recording will also be made available. And this is not the kind of thing that you listen to an hour presentation and now you can do CTGs. This is the kind of thing where you'll need to go and do some reading, you need to ask questions, you need to go through the recordings again. And this is an art that also needs to be developed over time. I'm just checking, there's no questions in the chat yet. And I don't see any hands at the moment. Doc, I think you covered an extraordinary amount of ground. That was an excellent presentation. Would it be possible for us to share the slides as well, Doc? Because I think you've got such lovely examples of CTGs and then their interpretations.
Sure. I'll talk to you about it. Okay. And then what I want to suggest to the colleagues on the group is that the Prof. Hofmeyer has done a workbook. So I think shortly, I think the most important thing to share is that workbook.
Yeah, we'll do that.
Because even if it does not classify the CTGs for you, you learn by the time you've gone through, it's not many slides. I think it's about 20 CTG tracings. You do the trace, you interpret, you do the trace, and then on the next page, it's got the answers and it's showing you the abnormalities. And I think doing that workbook sooner than later will be very helpful. And I think let's share that as part of the tools.
Thank you very much. Yes, I'll make sure we do that.
Okay, and then the other frequently asked questions, things that we often discuss. People will say, okay, Dr. Mandondo, this patient has come in ethanol-induced or intoxicated, right? Now you think she's intoxicated and her CTG is flat. How much time do you then give this CTG? Now you would have said 90 minutes maximum, but it remains, it remains still flat now after an hour or 2 hours. What do you do? So there is no cutoff time where we can say, no, if she's ethanol induced, but if you give her the fluid bolus, she'll sober up, she'll excrete the alcohol, and therefore she will really become better and the CTG will improve. So that's a very important, there's no cutoff time. If you've used drugs, for example, let's say the patient received pethidine, normally the CTG will be flat for about 50 minutes, and then after 60 minutes, it will improve. So I think you can just note the time of the pethidine, but if despite the pethidine wearing off, the CTG remains very reduced, then you can comment about it. Also the same with Maxalf, there is no cutoff time. You just need to just focus on the patient is on Maxalf, but you might not see something else now, like a slowing of the heart rate or a reduction in the heart rate. Then it means something more sinister is happening. It must just remain flat, which is what you kind of expect. I think those questions are common. And the other one that is actually common is that single prolonged decel. So really, if it's more than 3 minutes and really you cannot find an overt cause, you need to just continue monitoring for about but we said that if it's more than 3 minutes and our CTG sticker here is saying 5 minutes, then we need to consider delivery because the chances that this thing will repeat and kill the baby is very common. And then the other things we discussed, doctors, especially with the fetal tachycardia, doctors do not come out to see patients with CTGs that have a fetal tachy. The most frequent response is like, oh, just give her ceftriaxone and flagyl and just repeat the CTG in 2 hours. Colleagues, if there is a risk, someone has previous abruption or the person has actually got a previous seizure, you need to come out and rule out clinically the uterine rupture. see if the person is not obstructed, you need to come out. It's a different situation where you say that, oh, you tell the nurses to give the antibiotics because now they're seeing a tachycardia or a pyrexia, but it is not the actual management of patients. So I think I really want to emphasize those points because they are the loopholes. And we must remember, if you complete it on the sticker, it's very difficult to write notes. The variability was this. Just write on the stickers and circle the stickers and then write your name and write your actions on the sticker so that if there is a litigation or in the future they need it, then it's fine. Then you can go back to the sticker and you'll remember what you had interpreted it as or what were your findings, as opposed to just writing normal and suspicious, especially with the intrapartum CTGs. Please, we would really like to appreciate that.
Oh, thanks very much, Doc. That's the voice of experience. One can hear you've been on that edge, that cold face many times. Everybody just noticed there's a poll that's come up. The poll is useful for us also in terms of recording of CPD points. So it just confirms that you've attended the session. If you're not able to fill in a poll or the poll's not appearing, that's sometimes because you've got an old version of Zoom, then just please put your name in the chat to show that you are present and just tell us how useful you found this presentation. So either fill in the poll for us or just put something in the chat just so we can know that you were here. But I think from that point of view, we're going to complete this presentation. I'll stay on a little bit for people who are putting things on the chat or who are filling in the poll. Doc, thank you so much. The maternity pack is going to go out tomorrow, and then we'll add a whole lot of information and a lot of other excellent videos and webinars from last year and a whole bunch that Prof. Hofmeyr has put together this year, as obstetrics is a very practical discipline and much easier to learn through video than through textbooks sometimes. So we will be sending those out tomorrow afternoon. And then just a quick bump for tomorrow evening, we have Dr. Sean Geratif. She's an emergency medicine physician. They are hen's teeth in the public sector. And she's up in Livingston in Eastern Cape and very passionate about triage and emergency medicine in the rural health setting. And she's going to be doing a session for us on triage tomorrow evening, again at 5:30. And we will be making the recording available. Thank you very much, everybody, and have a lovely evening.